Dear audience, welcome to my 9-month progress report, where I present my projects that help strengthen the relationship of acute pancreatitis with cancer. My name is Jimin Lee, and I'm currently a 6th-year medical student at Semmelweis University. I'm also enrolled in the MD-PhD program with the Center for Translational Medicine. My vision is to improve the prognosis of pancreatic cancer. And to achieve this, my current mission is to prevent the progression of pancreatic cancer into its later stages by determining its early predictors. Currently, I have two specific goals. My first project will be a systematic review and meta-analysis, and my second project will be a registry analysis. My first project will be to investigate the effect of acute pancreatitis to the development of pancreatic cancer. Despite the advances in medical technology, pancreatic cancer continues to be a deadly force within the medical field, where it is predicted to be the second leading cause of cancer-related mortality by 2030. Pancreatic cancer is known for its asymptomatic nature, making it difficult to make an early diagnosis and often discovered in its later stages, where less than 20% of pancreatic cancer patients are eligible for resection at the time of diagnosis, resulting in a much poorer outcome. Therefore, there is a need to clarify various predictors of pancreatic cancer so that we can detect it in its earlier stages. Acute pancreatitis, which is one of the most common cause for inpatient gastrointestinal hospitalization, can serve as a possible indicator for pancreatic cancer. It has been previously associated with pancreatic cancer, however, its exact relationship continues to remain unclear. Therefore, our aim is to investigate the rate of pancreatic cancer diagnosis among acute pancreatitis patients. So to investigate this issue, we formulated the following question: does acute pancreatitis increase the risk of pancreatic cancer? We devised the COCOPOP framework where we want to analyze the incidence or prevalence of pancreatic cancer in the adult population with acute pancreatitis. And we believe that acute pancreatitis will increase the risk for the development of pancreatic cancer. And if our hypothesis can be supported with data, then we can establish an adequate follow-up strategy within the acute pancreatitis population so that we can detect pancreatic cancer at an earlier stage where the outcome is more favorable. If there's enough data, we also want to conduct a sub-analysis regarding the following question: what are the risk factors for pancreatic cancer in patients with acute pancreatitis? Here we designed the PFO framework where we want to see if certain risk factors will have an effect on the acute pancreatitis patients on the risk of having pancreatic cancer. And we believe that certain risk factors after acute pancreatitis will augment the development of pancreatic cancer. And for the clinical implication, if we can identify these risk factors, then we can also characterize a subpopulation who are at higher risk for developing pancreatic cancer so that we can devise an adequate follow-up strategy and detect pancreatic cancer at an earlier stage. So we conducted a systematic search on October 11, 2023 on 3 different online databases. We used a search key with 2 different domains, where the first domain contained different terms for acute pancreatitis and the second domain contained different terms for pancreatic cancer. We had a total of 32,000 articles, and with the help of my co-investigators, we were able to narrow it down to a total of 50 full-text articles that were eligible for my study. I also conducted a reference chaser along with my co-investigator, and we have completed the selection process. However, I have not gone through the conflicts yet, so I have not posted the data for that. So this is my current progress for my first project. We're currently working on organizing the data for the final data analysis, and here's the current general analysis plan. For the prevalence, incidence, hazard ratio, and odds ratio data, we have follow-up time, so we're going to use that and create some subgroup analysis. For my risk factors, which is my sub-analysis, we will be able to analyze the effect of diabetes mellitus and smoking on acute pancreatitis patients on the risk of developing pancreatic cancer. Unfortunately, I do not have any preliminary results, but I am privileged to present some preliminary data that was presented by the CTM Pancreatic Institute. They have an acute pancreatitis cohort of 2,364 patients, and they discovered that pancreatic cancer appears in 4.6% of idiopathic pancreatitis. Additionally, they also analyzed the patients who developed pancreatic cancer after acute pancreatitis, and they found that the average time for them to detect pancreatic cancer after acute pancreatitis was around 600 days, or 1.5 years. Meaning that acute pancreatitis can be a possible early indicator of pancreatic cancer. And this is significant because it tells us that there's enough time to detect pancreatic cancer at an earlier stage, as acute pancreatitis can appear 1.5 years before the initial diagnosis of pancreatic cancer. And moving on to my second project, I would like to investigate the prevalence of pre-existing malignant tumors in patients with acute pancreatitis. After discharge, the first-year mortality rate in acute pancreatitis patient was almost doubled compared to the in-hospital mortality rate, with age, comorbidities, and acute pancreatitis severity being the most significant risk factors for death. It was also found that acute pancreatitis-related mortality rate was 9 times higher in patients who are older than 60 years of age, which brings us to the question, is this increased mortality rate due to aging itself or due to other comorbidities that come with age? One of the possible comorbidities that was found within these patients was cancer-related cachexia, which brings us to the aim of our study, to investigate the prevalence of malignant tumors in acute pancreatitis patients. So with this being a registry analysis, we'll be able to evaluate several variables. So we constructed 2 different clinical questions. For the first clinical questions we want to assess is the following. Is acute pancreatitis associated with a high prevalence of malignant tumors? We constructed the COCOPOP framework where we want to analyze the prevalence of pre-existing malignant tumors in the adult population with acute pancreatitis. And we believe that acute pancreatitis is associated with a high prevalence of malignant tumors. And in a clinical setting, if an acute pancreatitis patient walks into the clinic, then the clinicians can be more aware that this patient may have an underlying or pre-existing malignant tumor. In my second clinical question, we divide into 2 parts. In the first part, we want to ask the following. What is the prognosis of patients with acute pancreatitis associated with malignant tumors? And we constructed the PECO framework where we want to analyze patients with acute pancreatitis and compare those who has pre-existing malignant tumors to those without cancer and assess the prognosis in each patient groups. Some ways that we can assess the prognosis is to analyze the hospital mortality, length of hospital stay, ICU admissions, and among others that we might find within the registry analysis. And we believe that pre-existing malignant tumors are the risk factors for severity and mortality in patients with acute pancreatitis. For the second part, we want to ask the following. What are the risk factors in acute pancreatitis patients for having pre-existing malignant tumors? We want to see if certain factors such as demographics, comorbidities, AP etiologies, and among others that we might find within the registry, and see their effect on the patients with acute pancreatitis on the risk of having a pre-existing malignant tumor. And we believe that the subpopulation of acute pancreatitis patients are at a higher risk for having pre-existing malignant tumors. And for the clinical implications, kind of similar to my sub-analysis in my first study, where if we can identify the risk factors, then we can also characterize a subpopulation who is at high risk for having a pre-existing malignant tumor. So the registry that I will analyze is an AP registry that was formed by the Hungarian Pancreatic Study Group in 2012. It currently has 27 uploading centers with a total around 4,884 cases. However, this number of cases may change depending on my eligibility criteria and also the data available for us for analysis. So the data was collected using 2 forms. The Form A, which is the data collected upon admission, and Form B, which is the data collected during the follow-up period. The blood samples and patient data were prospectively and reliably collected, making this a high quality and reliable data for our study. To summarize, I want to strengthen the relationship of acute pancreatitis with cancer so that we can use acute pancreatitis as a possible early indicator for detecting the cancers so that we can discover at an earlier stage. I would like to have my first study submitted and ready on October 2024 and my second study December 2024. And to end, I would like to quote Mary Curie, where she says, "Nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. Cancer is a terrifying disease because its nature is poorly understood. With my studies, I hope that we can better understand the nature of cancers through its association with acute pancreatitis so that we may fear less." Thank you for your attention.
That's a nice presentation. I would like to ask you, how can we screen this patient for malignancy after acute pancreatitis? What kind of malignancy, what measurement, laboratory, X-ray, or anything else? What is your suggestion?
Are you referring to my second project?
Yes.
So the data that was collected was with blood samples, and also patient data, it's like the clinical data. I'm not too sure what kind of data we have because they're still working on cleaning the data. But for me personally, I think we can do some accessible imaging such as endoscopic ultrasound or CT, MRI. Those are some more accessible. Yeah.
Right, thank you very much. Questions?
Thank you, Jimin, for the great presentation. You mentioned that thanks to the Hungarian study group, we received information that is 1.5 years after the appearance of pancreatic cancer.
Yes.
After the acute pancreatitis appearing the pancreatic cancer. So during your selection process or your data extraction collection, what have you seen? How long follow-ups are there? Is there any study that was particularly had a longitudinal design?
Yes, there was some longitudinal design where they had a cohort of acute pancreatitis and see when pancreatic cancer developed. And actually, one of the articles actually has similar data as to the CTM data, where the highest incidence was discovered within 2 years or 2 months. So this can show that there's an association between acute pancreatitis and pancreatic cancer, but not necessarily that acute pancreatitis can cause pancreatic cancer, but maybe the other way around.
And are there any confounding factors that might be considered as well?
Confounding factors.
Which might appear in the text, if you remember, just, of course. That can be the cause or that can impact as well the appearance of the cancer, not only the AP.
I don't quite understand your question.
Like you are investigating in your second project as well, that are there any confounding factors that might have an effect as well? Not only the AP, like were multivariable analysis done?
I mean, we are assessing for some risk factors and see if they have an effect on the development of pancreatic cancer, which is the sub-analysis. And we have enough data to assess diabetes mellitus and also smoking as well.
Thank you.
So in patients who have got pre-existing pancreatic cancer and who have a pancreatitis, in those patients, is it the pancreatic cancer causing the pancreatitis?
Yes.
And if yes, how?
Yes, it can be a possible cause that pancreatic cancer is causing the acute pancreatitis, because when pancreatic cancer develops, it creates a mass within the pancreas, which can block the ducts, causing the backflow of the pancreatic enzyme, resulting in the acute pancreatitis.
And can you explain the right-hand table, which I do not understand because there's no measure? What is the measure there?
Yes. So it's days.
Days, okay.
Yes.
Then I understand.
What is the mechanism of smoking and alcohol-induced pancreatitis? Many people drink and many smoke, even more smoke probably, I don't know. But still, they don't get pancreatic cancer. Is there any genetic cause that increases risk?
To my understanding, I'm not sure about the underlying mechanism of how smoking causes the pancreatic cancer. So unfortunately, I'm not able to answer that question.
I was paying attention, but maybe I wasn't paying attention enough. Will you look at the differences of the outcome of pancreatic cancer in those who had acute pancreatitis, and will you look at the non-pancreatitis associated pancreatic cancer diagnosis, and will you compare the two? To see what I get. So does a patient have a better outlook with a pancreatic cancer if they are discovered when they have a pancreatitis, or do they have a worse outcome when they don't have a pancreatitis before the diagnosis of pancreatic cancer?
That would be an interesting analysis, but that is not one of our outcomes for my study.
Maybe one last question. Have you included during the selection cross-sectional studies?
Yes, we have some cross-sectional studies, but most of them are retrospective cohort studies.
Okay, so you know that pancreatitis was before pancreatic cancer.
Yes.
All right.